welcome everybody for joining us today for this webinar, which is part of the Maternity Matters series. My name is Gynaecologist and I'm a Senior Associate Solicitor in the London office. Today's webinar is focused on the vital topic of prevention of injuries and injured myself during the birth of my first child, Maya, 16 years ago. I know personally the devastating long-term impact these injuries can have on women, both physically and psychologically, on one's ability to socialise and work, on physical intimacy, self-esteem, and the wider impact on the entire family. And that is why we are so proud at Owen Mitchell to work closely with the MASIC Foundation, which is the only charity to support women with severe perineal injuries. I'm really pleased to be able to bring today's webinar to you in conjunction with the MASIC Foundation, and we have a wonderful programme of speakers, full details of which are available in the webinar programme. I'm joined today by my colleague Anne Kavanagh, who will chair the Q&A session towards the end. Before we start, just some small housekeeping points. The recording of the webinar will be sent to you by email in the next few days if you would like to watch it again or share with colleagues. Some of you have already kindly submitted questions for the speakers, and you can continue to submit questions throughout the webinar using the Q&A function on your screen, and these will be addressed in the final panel discussion. When submitting questions, please, if you would like to, include your name and email address so that if we don't get to your question today, we can email you a response directly afterwards. And finally, towards the end of the session, we'll post a feedback link, and I would encourage you to please take a couple of minutes to complete that if you can. So a huge thank you to everyone who has signed up for today and for those joining us live. There's been a great deal of interest. And finally, thank you to our speakers for their time. We do have a very full programme, so I'll keep my introductions and comments as chair very brief. I first have the pleasure of introducing Jen Hall. Jen is the Digital Communications and Campaign Manager at the MASIC Foundation. She became involved with the charity after suffering a third-degree OASI injury herself after a forceps delivery, and she is passionate about campaigning for informed consent during childbirth. She has a focus on injury prevention and supporting women to share their stories of childbirth injury and trauma. Jen will be talking about the results of an online survey MASIC carried out examining women's experiences of childbirth injury via instrumental delivery in the UK. Thank you, Jen.
Hi everyone, thank you for the intro, Geeta, and thank you to Owen Mitchell for inviting me to speak at this webinar today. I'm going to be talking about the results of an online survey carried out by MASIC to explore women's experiences of giving birth assisted by forceps or Von-2s. As our webinar today is focusing on preventing injuries during childbirth, it's important to reflect on the role of instruments in this debate and to examine how their risks are communicated and what the outcomes are for those who've experienced an instrumental delivery. So in November 2022, MASIC carried out this online survey. The survey ran for 2 months across the charity's website and social media channels, and we received 703 responses from women who'd experienced an assisted vaginal birth in the UK. Next slide, please. The survey aimed to explore whether women were aware before going into labour about when an instrumental delivery might be needed, what degree of choice they were given, and if they were informed of their individual risk profile. If they were informed about any potential impact on their postnatal physical and mental health, and their experiences of their postnatal care and their postnatal symptoms. Next slide, please. So 93% of our respondents said that they experienced an assisted birth delivering their first child. 63% had a forceps delivery, and 24% a Von-2s delivery. 9% of our respondents reported that both Von-2s and forceps were used to deliver their baby. Next slide, please. I'm going to break down the survey findings into 4 key areas: antenatal information and communication of risk, findings around a trial of instruments, injuries sustained to mother and baby, and postnatal care and symptoms. Each area will include anonymous quotes that I will read from the survey, and I think they really are the most powerful evidence that we can present on this issue. Next slide, please. So firstly, looking at antenatal information. 82% of respondents were aware antenatally that instruments may need to be used to deliver their baby. The majority found this information from their antenatal classes, with only 16% being given this information from their midwife and just 5% from their obstetrician. A remarkable 20% of respondents said that they had to find this antenatal information themselves from the internet. Next slide, please. So 57% of respondents were not aware of the factors which mean that some women are more likely to need an assisted birth. These factors include delivering your first baby, the baby becoming distressed, having an epidural, the baby being too big for the mother's pelvis, and maternal fatigue. A large majority, 73% of respondents, were not aware that instrumental deliveries are associated with an increased risk of maternal injury. And 78% said that they did not have adequate information antenatally to make an informed choice about having an assisted birth and the type of instrument used. Next slide, please. Our anonymous quotes collected from the survey reflect this lack of information and consent. All the information I had came from my own research. Nothing came from my antenatal care. I was terrified at the prospect of forceps. The doctor refused to answer my questions about rationale, risks, or alternatives. I was not informed of the risks of injury, and I'm left with lasting damage from the forceps. No information was given to me about the likelihood or the impact of tearing, and there was no discussion of alternative choices, and no clear rationale was given for the need to have an instrumental delivery. Next slide, please. And further quotes on this reflect this lack of antenatal information. No information I read about instruments or birth talked about fecal incontinence, none. It completely minimised and misrepresented the injuries that you can sustain. I didn't realise the impact an assisted birth would have on my own physical and mental health. They need to make you aware of the injuries that can be sustained both to you and the baby. They are used too commonly, despite of the countless injuries caused. Next slide, please. So moving on to our findings around a trial of instruments. Just 32% of respondents had a trial of instruments in theatre discussed with them during the birth, which included the option of a C-section if the trial was not successful. 57% were not given the option of a trial at all, and 11% felt that they were too far along in their labour to remember what was discussed. A large majority of our respondents said that nobody explained to them at any stage antenatally or during the labour the risks of an instrumental delivery or an assisted birth compared to the risks of a C-section. Next slide, please. The survey comments reflect how women feel about this lack of choice. Von-2s and forceps were only suggested after 3 hours in second stage, and it was an emergency situation. I would like to have had my options discussed after 1 hour of unsuccessful pushing and then given the choice of a C-section. I raised the concern that my baby was large, and I was dismissed by all medical staff. By the time the birth was going wrong, there was no issue of choice. If I'd been given a choice, I would have had a caesarean, but no choice was offered to me. I wasn't given a choice in the forceps birth. I asked for a C-section as I was quite scared of forceps, but it wasn't allowed. I feel I was coerced into the procedure against my will. Next slide, please. Moving on to our findings related to injuries sustained during an assisted birth. A large majority of respondents reported that their baby sustained physical injuries. 84% reported marks on the face or head, and 44% reported bruising. Other injuries reported included a black eye, cuts on the forehead, a dent in the jawbone, permanent scarring down the side of the face, facial palsy, burst blood vessels, and damage to babies' necks and ears. Next slide, please. Injuries to mothers included almost a quarter sustaining an OASI injury. Another 21% sustained a second-degree tear. Worryingly, 33% of respondents reported that they've subsequently been diagnosed with a different injury to the one diagnosed immediately at birth. At MASIC, we're aware of many cases of missed third and fourth degree tears that are only found when women report symptoms in the weeks and months following birth. And at this stage, it's often more difficult to repair a missed tear. Next slide, please. Our respondents went into detail about some of the injuries they sustained and the impact this has had on their lives. I knew I had an episiotomy, but I only found out 10 months later when I had a birth debrief that I had a separate tear from my vagina to anus. I sustained an anterior, posterior, and uterine prolapse, and my tissues were severely stretched. I also developed rectal intussusception and have had severe problems going to the bathroom ever since. I spent 2 years following the birth, visiting GPs in tears, as I was soiling myself daily and was told it was nerve damage. My daughter was a toddler before I understood fully what had happened to me. Next slide, please. So how did our respondents find the postnatal care offered to them after an instrumental delivery? 52% said that the doctor or midwife who cared for them immediately following the birth did not explain the need to examine their back passage to check for tears. 58% of respondents did not have their perineum examined by their GP at their 6 to 8 week postnatal check. And a full 87% of our respondents have reported concerns about their health and well-being following their instrumental delivery. Next slide, please. These concerns are wide-ranging and have had a significant impact on quality of life for many of our respondents. 60% report ongoing symptoms of pelvic floor dysfunction or prolapse. 55% suffer traumatic flashbacks to the birth. 48% have been worried about their mental health, and 43% suffer with pain during sex. 42% suffer with involuntary loss of flatus, and 39% have been unable to return to activities that they enjoyed prior to giving birth. Next slide, please. 33% suffer with ongoing pain when standing, lifting, or exercising, and 33% also say that their bond with their baby was affected. 32% have been unable to make it to the toilet in time due to impaired bowel function, and 21% suffer sexual dysfunction. 6% of respondents said that they were unable to return to work due to the severity of the injuries that they sustained. Next slide, please. And this is the impact. Women report that they've been unable to have sex since giving birth. They've blamed themselves and wondered whether they'd have been better off not having a baby, with many being diagnosed with PTSD and birth trauma. One respondent describes feeling like she has a disability following her instrumental delivery, and I know many women who contact MASIC feel the same. These are not short-term postpartum issues. Many women are left having to navigate incontinence, pain, prolapse, and sexual dysfunction for many years following their injuries. Next slide, please. So what needs to change? What can we do to improve communication around the risks of instrumental delivery? And shouldn't it be the right of every woman to know those risks so that she can properly consent to instruments if they need to be used? Shouldn't every woman have the right to choose a C-section as an alternative to instruments if she considers those risks are too great for her future health and well-being? As an injured woman myself, I believe that all pregnant women should be given adequate information about the potential risks to both their short and long-term health from an instrumental delivery. And all pregnant women should also be made aware of the risk factors that lead to an increased likelihood of an instrumental delivery. And a choice between instruments or a caesarean section should be offered to all women where appropriate. A management plan could be agreed antenatally and written into the notes, and this could be signed by both clinician and patient as a form of consent. Final slide, please. Thank you for listening to our survey results today. To close, I want to say a huge thank you to all the women who responded to our survey. Your voices are being heard. The full survey report can be found on the MASIC website, and there will be a link in the chat today. Thank you also to the clinicians and the legal professionals on our panel today who are working so hard to improve maternal outcomes. Thank you.
Thank you, Jen. That was a really powerful study and a brilliant presentation of your findings. Chloe, the CEO of MASIC, will be joining us in the Q&A. I now have the great pleasure of introducing Theo Clarke. Theo was a Member of Parliament for Stafford and Chair of the UK Birth Trauma Inquiry. She set up and chaired the cross-party APPG and led the historic birth trauma debate in the House of Commons, where she bravely shared her own experience. I was there to hear that debate, and it was very moving for myself and all the other women that were there. Theo is going to talk to us about the recommendations of the Birth Trauma Inquiry. Thank you, Theo.
Thank you very much. And thank you to Owen Mitchell for inviting me to speak today at your webinar on maternity mattering and specifically looking at injuries during childbirth. Well, today I would like to share some of the stories that I heard in the landmark birth trauma inquiry in the UK Parliament. And I should start by saying that I know some of these stories are shocking, but I think it's very important that we do continue to listen to mothers and first-hand testimony. And I'll talk us through some of the recommendations of our cross-party committee of MPs and to understand the lessons for the many brave families that gave evidence to us. Let me start off by saying that I really believe that improving maternity care matters, and I'd like to call on the new government to listen to mums and to implement in full the recommendations of our report. I think it's very important that both the new Prime Minister and the new Health Secretary do ensure that they end the postcode lottery currently in perinatal care. And I'm afraid that is the evidence that I heard very clearly in both written and oral submissions to our inquiry in the House of Commons. But before I delve into the specific details of the report, let me start by sharing why tackling birth trauma and particularly injuries in childbirth is so personal to me. So when I gave birth to my daughter just over 2 years ago, I'm afraid I had very little understanding of the risks in childbirth or the potential chance of sustaining a birth injury from a vaginal birth. I ended up having a very grueling induction process and nearly a 40-hour labour. And afterwards, I ended up bleeding very heavily when my daughter arrived, having a postpartum hemorrhage. And I think, like many mothers, I'd imagined that first golden hour when my daughter would magically crawl up my chest and we would start breastfeeding together. Instead, what happened was I was separated from my daughter and rushed into emergency surgery. And I remember I lay on the operating table for over 2 hours without a general anaesthetic, and I was not given one due to an earlier epidural. And it really was the most terrifying experience of my life. I did think I was going to die. And at the time, I had no idea that I'd sustained a birth injury of a 3rd degree tear. And I certainly had no expectations of how it would affect looking after my newborn baby. And this was despite attending antenatal classes, reading and preparing as much as I could about childbirth, but really nothing had prepared me for that experience. And sadly, like many other mothers in the UK, I continue to live with those consequences, both physically and psychologically, of my own traumatic birth. And I think it's really important to say that I have been lucky. I was referred to specialist perineal clinic to access mental health services, but it was when I met with some mothers through the Birth Trauma Association and later when reading the many submissions to the Birth Trauma Inquiry that I discovered that unfortunately my experiences were not uncommon. So firstly, let me start with the scale of the problem. And we know that around 30,000 women a year are suffering from a traumatic birth, although I do think that this data is probably an underestimate. And we know that the physical consequences of birth trauma can be life-changing. You've just heard from MASIC, and many of us have been living with bladder or bowel incontinence, as I myself have experienced. And research also shows that around 4 to 5% of women are developing PTSD after giving birth. And I think when I read through the accounts for the inquiry, some of the most sort of devastating stories were those about birth injuries, reading about it causing a lifetime of pain. And many of the women told me that they could no longer work. They talked about their injuries destroying their sense of self-worth. They also wrote to me very movingly in some instances about having to provide round-the-clock care for their children, some of whom who'd been sadly left severely disabled as a result of their birth injuries. We also heard from women in marginalised groups, particularly minoritised ethnic groups, who I'm afraid to say had extreme poor care, with some even reporting incidences of racism. And during the inquiry, we also heard from some fathers and partners who'd also received psychological distress as a result of witnessing their partner's traumatic birth. And I think what's really struck me over the last year since my national campaign was launched to tackle birth trauma and how to improve maternity care within the NHS was firstly just how much it remains a taboo subject. And I think that really begs an important question as to why is it that the challenges and the risks associated with childbirth are still not being widely or publicly discussed in this country. So I hope that one immediate result from the inquiry is that by us as parliamentarians talking about it, we've started this national conversation on birth trauma and helped to break the stigma about talking about it. And Geeta, you mentioned earlier my speech in the House of Commons, and I very publicly decided to share my own story because I think it's really important that we hear first-hand lived experience and testimony in order that the government and the NHS can act and listen to those concerns directly. And what struck me listening to submissions to the inquiry was that I think we sometimes forget that there are two patients post-birth. There's such a focus on the pregnant mother and then the baby post-delivery that sometimes we forget about the mother's physical and mental well-being as being just as important as that of the child. And I was quite shocked to discover during my inquiry the very high levels, firstly, of costly litigation into maternity. And of course, that's money that could be invested and spent on frontline services and improving care in maternity to hopefully reduce those risks in the first place. And also to ensure that we do have a properly funded NHS workforce to deliver safe care. So to give you some background to the inquiry, and then I'll set out our sort of key findings. It was myself and the then Labour MP, Rosie Duffield, who founded the all-party parliamentary group on birth trauma last year. And this was important as it was really the first cross-party committee in Westminster to focus exclusively on birth trauma. And we received nearly 1,400 submissions from parents, families, medical experts, and I also chaired 7 public witness sessions in Parliament where we could hear directly those personal testimonies. And I'd just like to share a few of those related stories. We heard a specific session on perineal tearing, and we know that in most cases these tears are minor and can heal quickly, but sadly some women were experiencing 3rd and 4th degree tears. We heard about them causing lasting problems from urinary and bowel incontinence, chronic pain and pelvic organ prolapse, and that's obviously when the organ such as the uterus or bladder is descending into the vagina. And Professor Mike Keeley, a colorectal surgeon, told me that he and his colleagues had seen a very high referral rate in women aged 50 to 60 in whom incontinence or prolapse had either emerged for the first time or had become worse, all due to an injury during childbirth, which had become unmanageable later in life. I also heard many other stories where informed consent was not being sought. In one written submission, a woman wrote to me and described telling her community midwife that as a sexual assault survivor, her biggest fear was to have a forceps birth. And so in the case of an emergency, she would prefer a caesarean. But the midwife told her that a caesarean would be dangerous without any further explanation. And in the event, she experienced a frightening forceps birth, which led her to a complex 3rd degree tear and to 2 organ prolapses, leaving her in constant pain. And she told me that she felt if she'd been informed of the comparative risks, then she would have requested a caesarean. And she described to me feeling broken and permanently damaged, and adding that she used to believe that she was a strong and resilient woman, but, quote, birth showed me that I'm not. And in a number of cases, healthcare professionals seemed to be honest, quite ill-equipped to give even basic guidance about managing a tear. In our specific evidence session on birth injuries, I was told by one about being given a booklet where she was told that she should not wash her wounds until a gynaecologist told her otherwise. And she said, quote, "For 3 months with urinary and fecal incontinence, as well as postpartum bleeding, I hadn't been washing properly. Sometimes I think I can still smell myself, and on days when my mental health is really low." And I'm afraid that was a theme through a number of submissions. 22 women who wrote to me had specifically experienced a rectovaginal fistula, which of course is a hole between the rectum and the vagina. And shockingly, some of them did report being disbelieved by health professionals. One mother wrote to me, "In the months that followed, I suspected I wasn't healing well. I had many trips back and forth to the GP practice and to the local hospital. Nobody seemed to appreciate my concern that stool was leaking from my vagina. My GP questioned the direction I was wiping, which felt really condescending. And I was told by one gynaecologist that what I was describing was, quote, extremely rare and normally only seen in third world countries. I felt dismissed and unheard again." So I think many of the problems that we heard about in the inquiry also stemmed from a lack of understanding on the part of many health professionals. And that included GPs, midwives, and anyone who was assisting at the birth, partly because they said they were unlikely to see the woman again. And so many of them were not aware of the long-term impact. And I know Posy's here with us today, and she spoke to us as a midwife at the inquiry and talked about the lack of undergraduate training in pelvic health anatomy, and specifically the impact of tearing on women's pelvic health. And I know that there have been some changes, such as the planned introduction of pelvic health clinics as part of NHS England's new perinatal pelvic health prolapse service, but there's obviously so much more that we can do. So our findings very sadly demonstrated that there were serious failings across maternity care in the UK. And it is worth reading in full the report, but it is over 80 pages. So I'll just give you some of the headline findings today. But I think overall the stories told to us by parents were harrowing. I read accounts of stillbirth, premature birth babies born with cerebral palsy caused by oxygen deprivation and life-changing injuries with this result of a severe tear. And unfortunately, in many of these cases, it was due to mistakes or failures made both during and after labour. And unfortunately, frequently these errors, we were told, were being covered up by hospitals, and parents were being frustrated in trying to find the answers to these questions. I think one of the most distressing meetings that I had to have was when I met with some of the families from Nottingham who've been giving evidence to Donna Ockenden's inquiry. And, that meeting will haunt me. It was really distressing to hear the first-hand testimony of those families. And that's why I think this report is so important, because it gives the evidence to the government, but also a list of very practical recommendations of what the NHS and the government can do to change it. So a couple of the key themes that came through. The first was a failure to listen. Many mothers informed us that their concerns were being brushed off. This was true both pre and post labour. The usual response to concerns was to say that the mother was being overly anxious. I mentioned this point about informed consent, but this also was the case during vaginal examinations and cervical sweeps, and particularly with reference to the use of forceps and C-sections. And specifically on C-sections, many mothers who'd requested them had had their request denied, with one mother even being laughed at for asking for one. We also heard examples of poor communication, with witnesses to the inquiry not being told what was happening, of stories of notes being mixed up, and even examples of health visitors knocking on the door and congratulating parents on the birth of a child who had died in the hospital. And clearly these stories are completely unacceptable. I also heard stories of a lack of pain relief. Very high proportion of submissions talked about only being offered paracetamol, or in some instances nothing at all. And many women went through the entire birth without painkillers, including experiencing a third-degree tear. And the vast majority of the submissions did unfortunately refer to the lack of kindness being displayed by medical professionals. We heard stories of mothers being left covered in blood and faeces, hooked up to catheters and unable to walk, being chastised for not feeding their babies when they were too weak to even lift their babies to their breast. And many women talked about the lack of postnatal proper care. I heard mothers who found themselves in blood sheets, stained, thinking they were going to die whilst being left alone. One mother wrote to me that she was physically unable to look after her baby. She had her baby returned to her and was informed the baby had soiled itself, but rather than assisting her, the midwives told her to deal with the baby herself. And as she struggled, she heard the staff laughing and discussing which takeaway to order in the hospital. And many mothers told us that hospitals had failed to act with sensitivity once birth trauma had occurred. So whilst I recognise that some women in the UK would, of course, have had a good experience during childbirth, and that the vast majority of mothers will not be suffering from a 3rd or 4th degree tear like myself, and our inquiry did focus specifically on the negative experiences, we sadly did receive a very large volume of very shocking stories, but I hope that then by bravely coming forward, it will result in change from the government. So just to conclude, I just wanted to run you through our headline recommendations to the Prime Minister, which we summarised into sort of 12 key points. But our headline ask was really the need to introduce a base standard in maternity services across the UK. I was very struck that there are currently a number of different strategy documents relating to maternity, but there was no one single arching document. So I called for a national maternity improvement strategy to be published by the government in a single living document hosted on the gov.uk website, which must be continuously brought up to date. And specifically, the APPG also called for a new maternity commissioner who would report to the Prime Minister to be accountable for delivering those changes. Other recommendations that we brought in were to recruit, train and retain more midwives, obstetricians and anaesthetists to ensure safe levels of staffing in maternity care and provide mandatory training on trauma-informed care. Secondly, we asked for universal access to specialist maternal mental health services across the UK to end the postcode lottery. Thirdly, we asked for a separate 6-week checkup post-delivery with a GP for all mothers, and specifically this was to include separate question for the mother's physical and mental health in addition to the baby. And fourth, and very relevant to today, was to roll out and implement and underpinned by sufficient training the OASI care bundle to all hospital trusts to reduce the risks of injury in childbirth. Fifth was to oversee the national rollout of standardised post-birth services, such as birth reflections, to give all mothers a safe space to speak about their experiences in childbirth. Number 6 was to ensure better education for women on birth choices. All NHS trusts should offer antenatal classes. Risks should be discussed, both within antenatal classes and at the 34-week antenatal check with a midwife to ensure informed consent. Number 7 was to respect mothers' choices about giving birth and access to pain relief and keep mothers together with their baby as much as possible. Number 8 was to provide support for fathers and ensure that the nominated birth partner was continually informed and updated during labour and post-delivery. Number 9 was to provide better continuity of care and to digitise mothers' health records to improve communication between primary and secondary healthcare pathways. And of course, that needs to include the integration of different IT systems to ensure that notes are always being shared. Number 10 was to extend the time limit for medical negligence litigation relating to childbirth from 3 to 5 years. Number 11 was to commit to tackling inequalities in maternity care amongst ethnic minorities, particularly Black and Asian women. And to address this, we suggested that NHS England provided funding to each NHS trust to maintain a pool of appropriately trained interpreters with expertise in maternity and to train NHS staff to work with these interpreters. And finally, number 12 was for NIHR to commission research on the economic impact of birth trauma and injuries, including factors such as women delaying returning to work. And if you're interested to read the full list of recommendations, I have about another 40 at the back under sort of each individual subject. But I was very pleased that the former Health Secretary, Victoria Atkins, had accepted the APPG's headline ask for this national maternity strategy. They also agreed to the standalone GP appointments of the 6 to 8 weeks checkup post-birth and on physical injuries to roll out perinatal pelvic health services, including guidance to better support women who experience serious tears and to prevent these from happening in the first place. So that was an incredible result for our cross-party campaign to improve aftercare for mothers in the UK. But as I said in the beginning of my remarks, there has been since a change of government, and we now need to see the new Labour government step in and accept the recommendations that the previous government had committed to, and to go further and to look at all of the recommendations in our report. So I'd just like to finish by saying, firstly, thank you to so many of you on this call who I know gave evidence to our inquiry. To any of the mothers listening, I hope that you feel you have been heard and listened to. I welcome that some action was taken by the previous government. Rosie Duffield and myself are continuing our fight for all of you. And I really don't believe it's acceptable that mothers are not being listened to and that we continue to have a postcode lottery in this country. So I hope that no mother goes through the experience that I and Geeta and others have. But thank you for giving evidence to the inquiry. And I hope that it will be the voice for change for the government to deliver on improving maternity care and ensuring that no mothers who are suffering from birth injuries don't get the support that they need. Thank you very much.
Thank you very much, Theo, for that personal and brave account of your own injuries and a really succinct overview of the birth trauma inquiry and recommendations to hopefully prevent injuries to other mothers. What you achieved in a relatively short space of time has been really incredible. And I know personally many women who submitted their stories to you, and for some of them it was the first time they'd shared their experiences. So thank you. Theo unfortunately can't join us for the Q&A, but if there are any questions for her, then please send them through and we'll try to get as many of them answered as we can after the webinar. I'm thrilled to now introduce Dr. Susie Crowe, who many of you will know already. Susie is a leading voice in intrapartum care in the UK. She's a consultant obstetrician and gynaecologist, a national specialty advisor in obstetrics for NHS England, and the president of the British Intrapartum Care Society. Susie works tirelessly to improve maternity care and outcomes for both women and babies, and is presenting on the consensus statement for assisted vaginal birth. Thank you, Susie.
Thank you, Geeta. Thank you so much for having me today. And thank you to Owen Mitchell for inviting me. I really am delighted to be here. If we go on to the next slide, please, Pace. So why are we talking about this? Obviously, this whole session is talking about this today. But what I want to really emphasise is why we as obstetricians and midwives collectively are in this space and also talking about it. If we can go on to the next slide. So obviously we have heard, all of these stories and all of these awful stories about OASI tears, birth trauma, etc. But I also want to just kind of highlight, I suppose, what we also need to think about from our perspective as doctors, in particular, thinking about it in terms of equity, which is also about the longer term impact as well. So we know about the shame and the stigma, but obviously a big part of what I do is try to improve equitable outcomes. We know that women out there who experience birth trauma but have come from a high socioeconomic background can afford physiotherapy, they can afford personal training, etc. Whereas the women who have less access to health literacy, don't speak English, etc., often sit at home in deep shame and unable to exercise, and that in turn has this longer term impact on cardiovascular health. So not just the health of the mother from the pelvic health perspective, but actually thinking about longer term outcomes for them in terms of survival rates as well. And we know that obviously there has been previously patchy access to pelvic health care. We know that there is a pelvic health strategy, but I think there are still ways in which that we really need to improve this and thinking about this in the wider space. If we go on to the next, please. So the other sequelae. So what do we need to think about? So there is really something in here about how we get it right first time, and thinking about the other sequelae on women, families. You know, what I always think about in terms of our jobs is that our jobs is really to enable people to successfully transfer to and into their parenthood life. You know, at the end of the day, we all have children because we want to be parents, because we want to have family lives around us. And actually what we really should be thinking about in terms of maternity care is making that transition as positive and successful as we possibly can. And that really is the whole thing. And actually we know that if we get it wrong first time, then actually it limits people's choices around having further babies. They have bigger gaps between their children. You know, they sometimes don't want to have babies in the future, but also it's about how they then interact with us and the choices that they then make further down the line. And I know that we look after, and I certainly have looked after, a lot of women who are choosing care outside clinical guidance because they feel as though they've just not been listened to the first time round by healthcare professionals. They have a distrust in the medical model, and sometimes feel as though they need to be going outside guidance, or because we're not going to them and listening to them and really understanding why it is that they need to make those choices. But also we also know that there are more requests for intervention, and also we need to think about the counselling, who's doing that counselling, who's getting it right. So the thing that Theo just talked about, you know, with a community midwife talking about caesarean birth, actually it's obstetricians that we often are the people that need to be talking about some of these things from a birth choices perspective as well. But the way we've set our models up is that we often have it as just a consultant midwife led service, and then obstetricians sometimes coming in as almost gatekeepers to care. And as obstetricians, and I'm speaking very much from the obstetric community here, I really think that we need to be thinking about us in these spaces and us in these birth spaces, and kind of getting away from this idea that we have a much more medical model, and that we look after fetal medicine and maternal medicine, and that we really sit in this birth experience space as well. If we can go on to the next. And then the other thing really is about how we talk in silos. So I think, you know, we one of the great things about this webinar is the fact that we are trying to get out of this talking in silos, because what will often happen is that, you know, we'll sit in rooms, and I will sit in rooms with people, and, you know, with obstetricians, and the obstetricians will be talking about their fears and their pressures and what it's like, and how difficult things are for them. And then midwives might be talking in this room, and then obviously we might have, and then obviously service users, women, birthing people, families talking over here. And actually what we need to do is we need to be in these rooms together. You know, it can be really uncomfortable for us as healthcare professionals. You know, there was certainly I felt a lot of discomfort listening to Chloe and Theo's talks, but we need to own it. We need to know that this is what's happening, and we need to be in these conversations. But sometimes those are difficult conversations back and forth as well, from, you know, from the point of view of getting around the table. But we really need to be in these conversations together. And certainly as an obstetrician who represents the kind of intrapartum obstetric community, I want to make it really clear that we really want to be in these spaces. We want to be having these conversations, and in particular we want to be the people, I suppose, trying to make this change, but we need to be there in the first place. On to the next, please. So yes, we need to be around the table, leaning in and engaging. We need to be all willing to have difficult conversations. We need to be truly listening. Some of this is around advocacy for our own profession as well. You know, it is. We know that sometimes birth, and particularly in the second stage of labour, can be a really challenging and difficult thing. You know, the margins are fine in our jobs. You know, lives come and go very quickly. We have an extremely pressurised profession. It is an amazing profession. I absolutely love it. It's an absolute privilege to do what I do, but we need to be able to have that advocacy and that voice, and for me as well, to understand what it's like, not just for me as a consultant obstetrician, but understanding those pressures and what it's feeling like for my resident doctors at 3 o'clock in the morning, and the pressures that they're under, particularly regarding acuity, workforce, etc. We really need to promote equity, but also we need to be able to challenge that status quo and say, actually, what is happening right now and what do we need to change? On to the next. So in terms of the collaboration that's come together with all of this in mind, BICS, so the society that I lead, is really clear that we want to be really collaborative with people, and that at the heart of what we've done is create an MDT society that's not just obstetricians. We have midwives as part of our society, we have obstetric anaesthetists, we have neonatologists. Crucially, we also have service users, we have doulas, we have everybody coming together in this space. So it's not just one voice coming from different spaces, but actually we celebrate our diversity, and we celebrate the way in which we come together, and we really try to tackle these problems. So I'm delighted that MASIC, via Bob, who you'll meet soon, approached us to talk about how to improve assisted vaginal birth. Assisted vaginal birth is something I particularly am very passionate about. We know that it saves lives. We know that actually you can have positive experiences out of assisted vaginal birth, but the way we do it, and as obstetricians, can make huge differences to whether or not that's a positive or a negative experience. And I'm absolutely passionate about the fact that by changing the way that we practice, we can really change lives for the better. We've also been collaborating with the other big obstetric society, who are the British Maternal and Fetal Medicine Society, and this collaboration is also very much linked in with the RCOG as well. On to the next. So the vision that we've got together is to improve care for women and birthing people and families, particularly undergoing assisted vaginal birth, to really understand what matters to them, but also to understand about current UK obstetric practice. Why is it that we're practicing as we are at the moment? Theo's birth trauma inquiry heard about different practices from around the world, but we also know that there are different models of maternity care around the world, and we know that there are different patient demographics, and in particular the social determinants of health that we know that we are particularly seeing in the UK, particularly due to a lack of funding in terms of public health strategies, can actually very much impact on pregnant women and their outcomes as well. And sometimes in maternity, we're coming in on the end of that. We need to be promoting that, but also recognising what's going on in the wider scheme. But also we do want to learn from best practice. We do want to learn from the best practice within the UK and also outside the UK. We want to influence positively, but also we really want obstetric representation in policy creation, because, if we create recommendations and policies that sit here, but actually don't reach the staff on the shop floor, or don't have that impact and reach, we're not actually going to make those lives better. And actually that's what we're here to do. So we really need to be around the tables and involved with this, so that we understand what that gap is between how you go from a piece of paper to actually changing somebody's clinical practice on the shop floor at 3 o'clock in the morning. On to the next. And just what it's not, so in terms of this collaboration, what it's not is absolutely not rewriting of national clinical guidance. The RCOG has a great green top guideline, which is the standard around assisted vaginal birth. It's really not creation of dogmas or absolutes or unrealistic standards, and I think that's really important. And for my obstetric community as well, it really isn't about criticism. It's about of them. It's about understanding where we are now, how we can carry on to making maternity care safer, better, more effective and more personalised, but really kind of shifting that dial so that we're really understanding what women want and actually kind of going from good to excellent. On to the next. So this is about kind of creating opportunities through curiosity. So understanding work as imagined versus work as done. So again, we might have lovely policy documents or guidance, but actually that's great. But actually, what is driving practice and what's driving things on the shop floor? What are those things? Are they national guidance? Are they policies? Actually, is it local data? Is it quality improvement? Are people truly working with service users? We're seeing quite a lot of stuff at the moment across medicine in general around a fear of criticism and litigation coming through with defensive practice and the potential negative connotations of that. And actually it's about understanding that and understanding what's driving those practices, because actually, do we need to think about how to create more psychological safety whilst also providing safe care? Is it to do with training, or is it to do with something else? On to the next. So the other thing just to recognise is around the changing landscape over the last 5 years, and I think maternity care has changed so much since I started, so much, and I've been doing it for over 20 years. I think it's changed dramatically since the pandemic. It's changed dramatically even in the last 3 or 4 years. One of the things that we know that we've seen is a big driver around trying to reduce avoidable harm, and particularly avoidable term harm. So I think that some of the things that we had particularly seen in the previous 10 years, where we were using, for example, cesarean section rates as key performance indicators, have completely gone. And so we know that our induction of labour rate has gone up substantially. It's well over 40% in some organisations. Our cesarean birth has gone up significantly. So when I was a clinical director a few years ago, I would have to exception report a cesarean section rate above 27%, because that was that was our RAG rated KPI, and most units are reporting 40 to 50%. We are seeing a slight drop in assisted vaginal birth, and we're definitely seeing a drop in unassisted vaginal birth. That has all come with a drop in term avoidable brain injury and death over the course of the last decade, which has been quite a statistically significant drop. So we are seeing that drop, but those numbers are really small. And we also know that if you've got 10% of women having assisted vaginal birth, just in England alone, that's over 60,000 women. So we also need to be thinking about our kind of policy creation and how we cast our net very wide to achieve very small avoidable harm in some sections, but that might then have a knock-on effect in others, and how we do that. We also need to think about the workforce that we need for all of these things. And actually, if you look at this, that massive increase in workforce that we need from an obstetric perspective, from an anaesthetic perspective, etc. So it's not surprising that people are talking about not having time to deliver care, not having time to talk to women properly, not having time to see them afterwards and counsel and consent, when actually what we've done is we've increased our intervention rates without necessarily increasing the workforce to back that up. On to the next. And then also what we need to think about is that wider thing around perineal trauma. So what do we measure, and is this enough? Because obviously, again, all units will have a look at their OASI rates. They'll also have a look at their instrumental birth rates. But are we actually truly looking, and, in terms of benchmarking ourselves, our longer term things as well? So, are we looking at pelvic floor dysfunction associated with levator ani dysfunction rather than just OASI? Are we looking at things like PPH? Are we actually looking at the morbidity that is associated with some of these things for women? Or actually, are we thinking about them as just crude outcomes? And again, I'm really trying to get units to really have a think about the morbidity as an experience indicator. On to the next. And then, yes, this is just so that everybody knows where we are compared to the rest of the world. You can see that actually we do have a much higher rate of forceps in the UK compared to other places in the world. Next, please, Dace. So some questions that we wanted to ask ourselves, which was really what the current landscape is. How is intrapartum care actually being delivered in the UK? Have there been changes in practice over the last 10 years? What do obstetricians actually feel about their current practices, and are there differences based on your location or how long you've been an obstetrician for? So that actually, if we want to change clinical practice, first of all, we have to understand what it is at the moment. On to the next. But also, most importantly, and this is why it's been so important to have this as a collaboration, what do women and birthing people actually want in 2024? Because actually birth is a societal construct. We all know that the way that we function as women in society these days is vastly different to 20 or 30 years ago. I always think that sometimes women get pregnant and we think of them as being almost professional patients, as opposed to the fact that they are professional. We are professional women with jobs to do, with places to go, and that you can't sit there for hours just because your clinic is running late, etc. So actually, what matters to them? How do we provide that women-centered care? How do we personalize? How to improve? And also, obviously, that key thing about social inequalities and equitable outcomes as well. On to the next. So this is about being proactive and about us coming together to try to produce a statement that actually improves assisted vaginal birth through consensus. So these are the people that we've had around the table. We've got BICS, BMFMS, RCOG, RCM, BSUG, Pelvic Floor Society, MASIC, and obviously all the fantastic representatives from MASIC that you see here, and the Birth Trauma Association as well. And the idea is that we generate ideas and seek consensus on instrumental birth to make it safer, particularly themes around counselling, choice and consent, training in instruments, and producing a positive message for people as well. On to the next, please. So just very quickly, I'll touch on this. We did do 2 surveys of current obstetric practice across the whole 4 nations, consultants and SAS doctors, obstetricians, and we do understand that there's survey bias, but we have got some really fantastic data as a result of it. On to the next. So the first thing to say is that what we thought we knew is true to an extent. So we have seen a change in assisted vaginal birth from using, certainly when I first started training, the go-to instrument for absolutely everything was a ventouse, and we've seen that actually we have got more recourse to going towards forceps, and we wanted to understand why that was. On to the next. And that we got some qualitative answers around that. So some of it was around risk factors, so higher BMI, higher epidural use, something around defensive practice, so not wanting to have an instrumental in the room that didn't work and then having to go to theatre, so greater tendency to go to theatre and therefore a denser block and therefore needing to use forceps. A big fear of sequential instrumentation, so ventouse followed by forceps. Definitely some issues around training around kiwi. Definitely differences in the way we train and supervise obstetricians, and also a bit of a theme of moral injury coming through in some cases as well. So obstetricians feeling as though they can't provide the care that they really want to give, and there's a variety of reasons for that. And as I said, I think time and acuity is definitely one of those, along with various other different things like access to digital records and the amount of time that it takes to do that, for example, and that taking them away from being actually with women on the shop floor. On to the next. And huge amounts of information about consent and counselling, large variations in practice. Obviously, I think everybody felt that consent in labour is problematic, and we also know that. Obstetricians actually very much agreed with the findings that Theo has said around there need to be standardised education classes. NHS should be providing it, antenatal education being key, but also particularly in antenatal services, time being an absolutely massive barrier. And again, thinking about seeing the right women at the right time in the right place, and not being defensive and seeing women unnecessarily, every couple of weeks just because we feel like we need to, but actually really kind of focusing the care on the women in a really great focused appointment with the right people, maybe MDT, maybe having a one-stop appointment at the right time to actually provide the care that they really need. On to the next. So we've been building consensus. We've got a Delphi consensus group that's been backed by a comprehensive literature search. As I said, we've had MDT representation. There's been a lot of pragmatism behind it, a lot of listening, humility to learn with the same shared goal of coming together to improve care. And also, I think, just again, thinking about it in the longer term, the importance to make sure that when we kind of put this out, we reach all communities. And on to the next, please. So our overall themes was very much around communication and communication of risks, and I find it really fascinating that people think that if you give women true choices and tell them what the risks are of certain birth choices, that they won't choose them. And I say that as an obstetrician who had a forceps birth, and who chose to go for an complex induction of labour, knowing that might be the outcome, and actually many of my friends as well. So it just shows that actually we will know, if we know what women know what is being offered to them, it does not mean that they make different choices necessarily. What it does mean is that they feel empowered, and when that happens, and when that end outcome happens, they have felt empowered and in control because they knew all about it, and they knew that that was the choice that they were accepting. And I think that is an absolutely key thing for people to recognise. There's such a massive thing about how we make people feel in the middle of this, and actually the awful thing that comes through around, feeling like I was going to die is so much around not just what was happening, but how it was communicated, and that being such a massive thing about how we as obstetricians need to be being taught is about how we make people feel as doctors. There's things about autonomy and being truly listened to, postnatal debriefs, improving awareness amongst healthcare professionals and getting all obstetricians around this table, training, research, and also standardisation as well. On to the next. So what next? So the consensus statement is hopefully coming out next year. We are aiming for a big launch. We are collaborating in the recommendations. We are looking to see whether or not we need to change practice, and whether or not that's through different training, etc. But also we also need to think about unintended consequences of guidelines and policies, because actually I think that's a really big theme that keeps on coming through, that we try to fix one problem, but then actually another really big problem rears its head, and maybe we need to start getting upstream of these things. On to the next. And then I think just for any obstetricians or midwives on this call, thinking about what we can do as individual practitioners, which is around staying curious, thinking, can I actually change my own practice? And am I brave enough to think, actually, maybe I've been doing it wrong? Because actually, if you have been doing it wrong, that's a really hard thing to accept. I also know as an obstetrician, I can tell you about every single one of the OASI tears I have caused essentially through an instrumental birth, and how much that's affected me and how devastated I have been, and the importance actually of retaining, I think, that knowledge that actually you really care and not getting hardened to it. But also that, that how much you then learn from the patients and learn from the collaborating with the women as a result of that, and what really matters to them, particularly when you follow them up postnatally. We also need to use data well, we need to listen, we need to be humble, and as I said, we also really need to champion obstetric involvement in birth options debriefs, and crucially postnatal care as well. On to the next. And this was our theme of our BICS conference overall this year, which actually went down brilliantly, and we did a talk on this. So we are changing the dial. We've talked on this. We had talks on birth trauma. We had talks on trauma-informed care. We have some absolutely phenomenal service users who came to talk about things with us. And I really think that our big thing was around communication and how we make people feel, particularly at times of vulnerability, actually really changes lives. And that's it. Thank you very much. I'm sorry I've overrun a little bit.
Thank you, Susie. Having been part of the Consensus Statement Committee, I think it's one of the most efficient and effective and importantly collaborative processes I've seen to hopefully create real change in practice and improve maternity care for women and birthing people. So thank you very much. I have the great honour of introducing our final speakers, Professor Robert Freeman, consultant gynaecologist, the past president of the International Urogynaecologist Society, and member of NHS England's Perinatal Pelvic Health Initiative Implementation Group, among many other accolades. And Posy Bidwell, Deputy Head of Midwifery at South Warwickshire Foundation Trust and Clinical Research Fellow for the OASI Care Bundle. Bob and Posy are going to be talking about why the OASI Care Bundle was developed and its effectiveness to protect women from the debilitating consequences of severe perineal trauma. Thank you, Bob and Posy.
Thank you, Geeta. Thank you for that, for the introduction, and thank you very much for having us today. Bob and I are going to tag team a little bit, so we'll be switching between us. So we're going to talk about the OASI Care Bundle, and as Susie's already talked about, it's so important for midwives and doctors to be talking and working together. And that was one of the really exciting parts of the OASI Care Bundle. It was developed by obstetricians and midwives and women as well, to really try and understand how we can reduce the effects of these injuries. Next slide, please. So these are our declarations of interest. Next slide, please. So as you're aware, an obstetric anal sphincter injury is the collective name for third and fourth degree tears. As we've already heard so powerfully from Jen and Theo and all the stories that you've heard, there are major consequences of having an OASI. These include anal and fecal incontinence, adverse impact on body image and self-esteem, multiple attendances for hospital and community treatment, caesarean sections for subsequent births, painful intercourse and psychological disorders. Next slide, please. These are some quotes from some women who have experienced an OASI. Next slide, please. So I'm going to hand over to Bob, who's going to talk about the history and the development of the care bundle.
Well, thank you, Posy, and thanks to Owen Mitchell for this really kind invitation to be with you today. You've just heard about what the devastating consequences of an anal sphincter tear can be, and I've heard previously in other talks about the devastating impact of fecal incontinence, probably one of the worst things that any human being could suffer from. Back in the day when I was around this time on this slide, when I was doing active obstetrics, I was being called in for lots of very bad third and fourth degree tears, more than I'd seen before. And I spoke with colleagues around the country and they all said to me, yeah, we're seeing much the same. Then this paper was published. Next slide, please. And you can see that the incidence, in fact, of OASI had gone up. Now we have to look at reasons for that. First of all, yes, there's a higher risk population with older mothers in their first pregnancy. We know the average age at first birth has gone up. the obesity crisis with type 2 diabetes, and as a result of that, bigger birth weight babies. So those are known risk factors. It may also be the rate's gone up because we're better at detecting it. And there's been improved recording, probably through increased awareness and training, which is excellent. But it probably means that we've been underdiagnosing it for years. There's another factor that probably has been important, and that was the change in the management of the second stage of labour that came in some years ago, where there was no longer support of the perineum or the same degree of control of the baby's head at delivery. Secondly, there was a massive reduction in episiotomies, and there was an increase in forceps rates, as you've heard, all potential risk factors. Next slide, please. Now, in Norway, they've been very heavily criticised for their high OASI rate, and were charged with bringing in a package of measures to try and reduce that rate. And this involved getting the hands back on the perineum, as you can see with the so-called Finnish grip here, and episiotomy, and only when it was indicated, to be done at the right angle, well away from the anus. Because the closer the episiotomy is to the anus, the higher the risk of the cut extending into it and creating an OASI. So that was part of the package, along with, of course, good communication, making sure the woman was in a position she felt comfortable with, and also that the perineum could be visualized. So let's look at what they actually found. Next slide, please. They trained everybody, from the most senior obstetrician to the most junior midwife, and look what happened to their rates, a massive reduction. And in a recent analysis, over 20 years, they've shown that rate, the consistent and significant decline, that's been maintained. So the rate now is less than 1%. Next slide, please. So you can see in this country, we decided to do something similar. Now, at the time, as I said, I was very concerned about the number of OASIs that I was seeing, and I approached the president of our Royal College, David Richmond, who called a summit meeting at our college between our college, the College of Midwives, and invited the NHS England, along with the Care Quality Commission. And it was recognised and acknowledged that there was an issue, and something really did need to be done to prevent the problem. So this statement was made, as morbidity is considerable and can influence decisions about future birth, prevention of trauma is a priority. So that was great. So what then happened was I think it was NHS England suggested that we have a care bundle similar to the one in Norway. So groups got together, including the London School of Hygiene and Tropical Medicine, to look at all the different interventions and the evidence behind them, and to come up with a systematic review. And as a result of that, 4 interventions were chosen for the OASI care bundle. It was piloted in my centre and also the one at Mayday in Croydon. And then a grant application to the Health Foundation was made, which was successful, for a quality improvement programme in 16 units around the country. Next slide, please. And Posy is going to tell you about the 4 elements of the care bundle and the results of the 2 studies, that quality improvement programme and the implementation study. Posy.
Thank you. Next slide, please. So a care bundle is a set of interventions that when used together are effective. So we had 4 elements to our care bundle. One was around antenatal information for women. So this provided information as to what perineal trauma is, what the different types of tearing that can occur, and talked about what the care bundle was going to involve and where we were doing it and how we were going to evaluate it. The second component was around manual perineal protection for vaginal births. The third element was episiotomy at a 60-degree angle, and this was really only if episiotomy was clinically indicated. And the last element was doing a perineal examination after a vaginal birth to include a perectal check. This was to systematically understand what type of tearing had taken place so that any injuries could be quickly assessed and quickly repaired. The care bundle was underpinned by good communication throughout, so good communication for each of the care bundle elements, and emphasis was placed on facilitating a slow and controlled birth. Next slide, please. So the study protocol was published, so you're able to read this in your own time. Next slide, please. So next slide, please. Thank you. So as Bob's already said, it was implemented in 16 units across England, Scotland and Wales. And we had 2 main aims really of the care bundle. So it was to understand whether the OASI care bundle was clinically effective, was it acceptable to clinicians and to women, And the care bundle was also, it was rolled out within each unit by having a midwife and a obstetrician champion who worked together to do all the training, to raise all the awareness. So it really was a big multidisciplinary activity. And the study took place between 2017 and 2018. Next slide, please. So was it effective? So what we found was the OASI care bundle was clinically effective, and we found that it decreased a woman's risk of having an OASI by 20%. And that was if the woman gave birth in a unit that had used the OASI care bundle. So we had actually included over 50,000 vaginal births in that analysis to give us that finding. What we also found was there was some concern when we started talking about the OASI care bundle that we might increase our rates of episiotomy or our rates of caesarean sections, and we found that throughout the project the rates of episiotomies and caesarean sections remained unchanged. Next slide, please. So what were the barriers and enablers to implementation? So as part of the evaluation, we wanted to understand what the clinicians felt about using the care bundle, and also what the women felt about using the care bundle, and what were the barriers and enablers to introducing such to the care bundle to these sites. So in terms of the barriers, we really found that one of them was around lack of physical skills. So people talked about the fact that some midwives hadn't ever done an episiotomy, or they hadn't done an episiotomy for a very long period of time. So they were very, they lacked confidence in being able to do this. There was also a barrier around it. Some people talked about observing negative outcomes in terms of they were observing an increased number of anterior tears when they were using the care bundle. And then there was a barrier in terms of perceptions of what women want. And this was particularly around use of the antenatal information leaflet, which had a picture of a perineum on. It was a diagram and talked about perineal trauma. And we found that some of the clinicians were reluctant to give women this information sheet because they felt that the information was scary and they didn't want to scare women. There was also a barrier in terms of professional values and autonomy. And we were using the care bundle to standardise practice, and some clinicians felt that they were being told what to do and they'd practice in a certain way for their period of their clinical life, and they didn't now want to be told how to practice. Also, we found some enablers, though, which is really positive. So in response to some barriers, we also found some enablers. So some enablers to use in the care bundle around organisational support. So having senior support from your clinical director or your head of midwifery was so important when rolling out a new initiative. Some units felt that when their head of midwifery came round and said that it was really great that they were introducing the care bundle, that this was a really positive thing. Observing success. So this was a really positive enabler. So one of the units talked about detecting a sphincter injury on an intact perineum using the PR examination, and that was actually a really good selling point. The supportive service units, so women really wanted to come to units where they were using the care bundle because they felt that this was a really positive initiative, and it increased team cohesion, so midwives and doctors were working together. Next slide, please. So we also asked the women what they wanted and how they felt about the care bundle. So we asked them whether they felt the clinician's hands on their perineum. Some of them recalled feeling their midwives or the obstetrician's hand on their perineum, and they felt that this was a supportive thing. They really felt that good communication was key, and that they really wanted, overwhelmingly, they wanted more information about perineal trauma antenatally. Next slide, please. And these are some of the quotes from the women who we talked to. Next slide, please. Next slide, please. So I'm just going to briefly talk about OASI 2. So we found that OASI 1 was clinically effective. So we wanted to upscale the project to understand how we could do that. So we had our initial sites, we took on 20 more sites, and we tried different implementation techniques. So we looked to see whether if we buddied up units, that would be an effective way to roll out implementation, or whether we just gave units the toolkit, whether that was an effective way of implementation. So that's what we were looking at in OASI 2. Next slide, please. So what we found in OASI 2 was that we were able to maintain our low rates. There was no significant difference in the way that the units rolled out the implementation, but we really found that there needed to be more focus on creating opportunities to implement the care bundle, more mandatory training and more access to training resources. And again, more discussion, more standardisation about the antenatal discussion to support women in their decision in childbirth. Next slide, please. And, you know, what we found in OASI 1 and 2 really is being replicated in other studies that are being done. Some recent studies have found that there is a lack of confidence in perinatal management. The majority of midwives would like more education on how to prevent perineal trauma. There are low levels of confidence at performing episiotomies. Some midwifery students felt that pelvic floor teaching was insignificant. Many students can qualify to become a midwife without ever having performed an episiotomy or have done any suturing. And I think that that's, you know, really sort of adding to that sort of feeling that people aren't confident in their skills in perineal management. Next slide, please. I'm going to hand back over to Bob, who's going to talk about some challenges.
Well, thanks, Posy. And yes, I think you've alluded to the challenges that are already out there. And there was a great deal of negativity when the OASI Care Bundle first came in. And maybe that's because, you know, of what the previous slide, that maybe there was lack of confidence in management of the perineum because of a lack of training or a lack of understanding what could happen long term from an OASI, because obviously the vast majority of midwives and obstetricians wouldn't see these women in the longer term. So I think things have changed a lot by raising awareness, and that's come through, as Theo was talking about, through the all-party parliamentary group. Next slide, please. And also through the Perinatal Pelvic Health Initiative. So awareness is increasing, and I think the negativity we saw is much less. But nonetheless, as Posy's alluded to, there's still an anxiety that if you tell women too much, they'll all might ask for caesarean section. In the OASI Care Bundle study, there was no increase in section rates, even though we told them about the risks of OASI, fecal incontinence, and so on. But I think one way of getting around this, next slide please, is by assessing risk. NICE have come out with the risk factors for all forms of pelvic floor dysfunction, including OASI, and these are they here. But if a woman's got all of these, are we going to tell her, yes, you're at higher risk of developing this? Will that, as Posy said, create anxiety and fear? Next slide, please. One way around this might be is if we could provide women with not just an average risk of 10% of this or that, but what is your risk compared with that 10%? If we could give them their individual risk, that might help to reassure them. And that was the idea behind, next slide, please, this thing called Your Choice, which was an idea some of us had a few years ago. They were based on two big long-term studies after childbirth at 12 and 20 years, looking at incontinence, both bladder and bowel, and prolapse. And there were studies from New Zealand and the UK and from Sweden. The two databases were put together to identify the risk factors, which were similar to the NICE ones. And then the group collaborated with a team in Cleveland Clinic in Florida who were developing a risk calculator. Now, risk calculators are used in all forms of medicine, for example, breast cancer, heart disease, prostate cancer, to give people their risk of disease and progression and so on. So what happened was a risk calculator was developed. Next slide, please. And this is it. It's the Your Choice Risk Calculator based on these studies, and that's the website anybody can access. On the far left are the risk factors, and that's what Your Choice acronym stands for. And those are the risk factors for pelvic organ prolapse, urinary fecal incontinence, or any pelvic floor disorder, following a natural birth and following caesarean section. And on the far right are the average risks of not just any prolapse or incontinence, but symptoms that are bothersome enough to need treatment in the long term. So if a woman comes along and says, I'm really worried about developing fecal incontinence when I'm 40, and they've no risk factors, and she says, I want a caesarean section. If you put her into the calculator, next slide, please, you'll see she's at very low risk. And in fact, caesarean is unlikely to give any benefit at all. So in a woman like that, we can reassure her that her risk is extremely low and that maybe caesarean isn't the right thing, but rather physiotherapy, next slide, please, may be the way forward. And the evidence is very clear for that. It's been shown to be by far the most cost-effective intervention for not just prevention, but for treatment as well. And studies have shown a protective effect for 3rd and 4th degree tears and the consequences. The great thing is, as you've heard, this Perinatal Pelvic Health Initiative has been introduced as part of the NHS England long-term plan to provide pelvic floor muscle training, either with a physiotherapist or another allied health professional who's been trained to teach pelvic floor exercises, has been brought in for all women after birth. So this is a really exciting development and could really make a massive difference. And that your choice thing might be useful, because if you've got a woman who's high risk, then she can go to a physiotherapist. Somebody who's low risk could go to another healthcare professional who's been trained to teach the exercises correctly. Next slide, please. So that's for the low, medium risk women, but we can't ignore those who've maybe got numerous risk factors and are at high risk. So if you put somebody like this into the calculator, let's just look, for example, at prolapse for a moment. Her risk is double the average risk if she delivers naturally. And if she's a caesarean section, it's 4 times less. So in a woman like that, she should be counselled about the potential risks of natural birth, as per the Montgomery ruling in the Supreme Court case in 2015. In other words, that you must explain those risks in the same way as you would the risks of caesarean. And if she wants a caesarean, fine, but she may not. So therefore, we'd say, well, physiotherapy both during and after delivery. We'd probably say in labour, let's try and avoid forceps and maybe think about a vacuum instead, which has less risk. And if, for example, there were signs of obstructed labour, then maybe a consideration should be given to earlier caesarean rather than waiting till the woman's almost about to deliver. So there would be a management plan for that particular woman. Next slide, please. So of course, we've talked about other anxieties and fear, as Posy said, about giving more information about risk. Next slide, please. This was a qualitative study which was asking women, what would you think if you were told about your individual risk? And obstetricians and midwives were asked the same. Well, unsurprisingly, the women said, of course I want to know what my risk is. But healthcare professionals were worried it would increase section rates. But as you've heard from the OASI Care Bundle study, there was no increase in section rates. And in this study, nobody mentioned caesarean either. What they did say was that if they knew their individual risk, it would facilitate informed decision making, and very importantly, they would be more likely to do their pelvic floor exercises than if they didn't know their risk. So that's very positive. Next slide, please. On the other hand, for midwives and obstetricians, this created a particular challenge because they don't routinely discuss this, mainly because of time constraints. And of course, the main focus is on the immediate issues around labour and delivery for the safety for the mum and the baby, not necessarily the long-term risks to that mum. Yes, obstetricians would ask women about 3rd and 4th degree tears, who'd had them, about the next birth. But the real challenge is time constraints. With so many things to do, midwives and obstetricians don't have time to go through all of this. And that's the challenge that needs to be addressed. What I would say is that your choice risk calculator actually takes less than 3 minutes to complete. So if that was done, the woman comes back the next time, there could be a more detailed discussion about the preventative plan. Next slide, please. So that's a bit about the challenges, and Posy's going to look at how we maybe can overcome those more further. Posy.
Thank you. So going back to the OASI Care Bundle, so it is now recommended in part of the perinatal pelvic health workstream guidance. We've also tried to understand from one of our original sites as to what their experience has been since they started implementation. They have reported that they do see fluctuation in rates, but they do always do an audit if they see any spikes. They've indicated that the care bundle is fully embedded. It's included in their guidance. It's used in all birth settings, hospital, theatre, labour ward, MLUs, and at home as well. They also teach it during monthly suturing sessions with their newly qualified midwives, and it is something that they record on maternity EPR. They do, however, continue to have challenges. They say that the hands-on technique is done in varying different styles. Even though they teach it in a standardised way, people will then use it with varying techniques. There's still healthcare professionals are rarely using warm compresses, and there is still a variation in antenatal information that women receive. Next slide, please. So just finally, what else can be done? So Theo's talked about the 12 recommendations from the All Parliamentary Group, but what can we as clinicians do now ourselves? So we can use the OASI Care Bundle. We can talk to women about antenatal education. It's within our gift to be telling women. Overwhelmingly, women have told us that they haven't had enough information antenatally. They're also, we can do this. We can provide support for fathers and birthing partners, and we can reflect on birth experience. And similarly, I would add to this, we can do more postnatal checks as well, in terms of ensuring that every time you see a woman who needs a postnatal check, please ask to check her perineum, ask about symptoms of incontinence, ask how she is feeling. We can do more training around mode of birth. We can do training on instruments. We can talk about risk assessment, as Bob's already talked about. Make sure we risk assess every woman. What's her risk of tearing? What can we do to reduce that risk? Signpost to organisations such as including MASIC. And we can look at introducing mandatory training. As I've already said, students will have a varying experience of what anatomy and physiology they're taught with regard to pelvic health throughout their degree. And once they qualify, yes, they will do some suturing workshops and will be signed off for suturing, but then that's it. There isn't a mandatory study day that we have to do each year. We all do our fetal monitoring mandatory training each year. We all do our emergency skills and drills each year, but we're not actually doing anything mandatory with regards to perineal health. Good pelvic health is so important to women, and actually we should never underestimate the impact that it can have on women's mental and physical health. So we really need to be doing as much as we can to ensure good pelvic health. Next slide, please. Thank you. So this is just a big thank you to everyone who was involved in OASI 1 and 2. Thank you to the Health Foundation who funded it. And if you want more information about the Care Bundle, it's all on the RCOG website, including a perineal tears hub as well, and all the papers that we publish with the results on there as well. Thank you very much.
Thank you for that brilliant and informative talk, Bob and Posy, and for all of the work you've done with the OASI Care Bundle and reducing rates of perineal injury. And thank you to all of our fantastic speakers this afternoon. I'm now handing over swiftly to my colleague Anne Kavanagh, who'll be chairing the Q&A. Thank you, Anne.
Hello, everyone, and thank you again to the speakers from earlier. We have retained most of our speakers so far, apart from Theo, who had to leave earlier. And we are also joined by Chloe Oliver, who is the CEO of the MASIC Foundation charity. We've had quite a few questions from people who registered in advance, but as you're all probably aware, time is probably against us. So I'm going to limit the question really to one that I think probably covers all of the key issues we've discussed so far, although focused on a particular section of the pregnant population. And that is regarding perineal assessment and avoidance of OASI in women or people with dark skin tones during birth. Can any particular members of the panel provide guidance on what to look for so as to avoid or limit the risk of that injury? Let's see. Bob and Posy, since you've led on the OASI Care Bundle, do you have any specific guidance in relation to women with darker skin tones?
Posy, do you want to answer that?
Sorry, I was just trying to unmute myself. Sorry. So I think in terms of every woman should be risk assessed. Every woman should have the same, should have information about perineal trauma, what perineal trauma is, what can be done to minimise her risk. So in terms of antenatal information, are they aware? Are you talking about antenatal perineal massage? This is something that everybody can be doing, everybody can be talking about. This, has been shown to reduce the risk of perineal trauma. When a woman comes in labour, it's really about risk assessing everybody, making sure that she is mobile during labour if she can be. If she does have an epidural, make sure that she is not, in lithotomy, and making sure you can visualize the perineum as well. So good lighting, visualizing the perineum, and it's really about that good communication as well. So ensuring that slow and controlled birth is so important. So, sort of expulsive birth, can potentially lead to more injuries. So slow and controlled birth, once the baby has birth, really good visualization of the perineum, so good lighting. Make sure you, again, that good communication with the woman. Talk her through what you're doing, saying, I need to visualize your perineum, I need to understand what type of injury you've had, and this is what I'm doing. Keep talking, keep that communication, and it is about having that good visualization as well.
And I think also, I mean, the evidence suggests South Asian women tend to be at slightly higher risk of an OASI as well. Now, while some people believe the perineal body may be slightly shorter in these women, there's not a lot of evidence for that, but therefore the risk of tearing may be higher. But in people who are more dark-skinned, I mean, I suppose the only thing might be keloid formation if they've had a bad tear, so they may be more prone to pain afterwards.
Right. And this is partly addressed to all of you, I think, but it's around challenges with implementing the OASI Care Bundle. Have you found that it has been challenging to bring along practitioners, or what has been your experience of that?
So I think I mentioned some of the barriers in our talk. So yes, there were challenges, and one of them, there were challenges for each element of the care bundle. So there are 4 elements of the care bundle. There was challenges around providing antenatal information to women. As I've said, some people felt that it was scary, but actually conversely, I had a lot of reports from healthcare practitioners who said that women had brought their leaflet along to a consultation and said, I've been given this, and it actually acted as a prompt to have a discussion, and actually the clinicians actually found it really useful. There were some barriers around using a hands-on technique, because some people felt that they didn't want to use a hands-on technique. They'd not been taught it that way, or they'd never practiced hands-on, so they didn't want to start. So that was another of the challenges as well. There was a challenge around episiotomy. So I think there was a bit of miscommunication that we were encouraging episiotomy, and actually that wasn't the case at all. It was about doing an episiotomy when it was clinically indicated. So we were very clear on that message that episiotomy was only done if it was clinically indicated. And lastly, around the perectal check, there was a bit of challenge around that, because people didn't really understand why we were doing it. But you can't do an accurate assessment of the perineum and assess for damage unless you've done a rectal examination as well.
Yeah. I think what was, lots of things have been fascinating about today's webinar. One, not least of them, was the reference to the UR Choice tool for assessing both immediate and future risk. And I think there's a reluctance, I know from speaking with expert midwives and clinicians and so on, to discuss too much in the antenatal period, focus on risks and so on. But from everything you've said, it sounds as if the work towards reduction in OASI injury has to be during the pregnancy period, the pre-pregnancy almost period for some women, and to enhance the antenatal education if possible. I think we seem to have lost Bob there. Posy, would you agree
absolutely.
with that?
And sorry, if I can just say a final word, if that's okay. I think, we've all talked about how important information is, how empowering it is. Susie talks very much about how empowering information is to women, how it enables them to make an informed choice. We all recognise the pressures of the time constraints within an antenatal appointment, but actually this is such an important part of labour and birth. We need to be getting it right. So the more information you can give women, the better.
Yeah, that's great. I'm sorry, Chloe, we haven't come to you at all, but I would say about the charity, the MASIC Foundation, that there will be a link on the notes alongside the webinar, which will be posted in a few days. And for anyone who's joined, and indeed if you watch the webinar subsequently online, please do complete a feedback form. It's always helpful. It helps us to plan future webinars. So finally, just a thank you to all of our contributors today. It's been fantastic, and hope to see you all again soon.